Good morning. Today we are going to discuss about blood transfusion reaction. As we all know, blood transfusion is a life-saving process. In spite of taking all the precautions and laboratory testing done, sometimes there may be chance of some harmful reactions to the body of the patient after blood transfusion. These type of reactions are generally called as blood transfusion reactions, and the definition, classification and management of blood transfusion reactions are being discussed in this topic. First, about the definition. Any harmful and unfavorable transfusion related events occurring in the patient during or after transfusion of blood or blood component is called transfusion reaction. That's any unfavorable or harmful reaction occurring in patient after the transfusion of blood or blood component is called transfusion reaction. Next, about the common causes of transfusion reaction. Causes can be misidentification of the patient, improper sample identification, wrong blood issued, administration error, technical error, storage error, etc. Next, about the types of transfusion reaction. Mainly, the transfusion reaction is classified into immune mediated and non-immune mediated. This immune mediated is classified into hemolytic and non-hemolytic, and both is divided into immediate and delayed type. And non-immune mediated is classified into immediate and delayed. Next, about the first classification, hemolytic transfusion reaction. Hemolytic transfusion reaction are most severe type of transfusion reactions and can be categorized into two types, that is immediate and delayed, intravascular and extravascular otherwise. First, about intravascular hemolytic transfusion reaction. In intravascular transfusion reaction, the hemolysis of RBC takes place within the circulatory system. The hemolysis occurs within few minutes after starting the transfusion. And this type of reaction is mainly due to antibodies to blood groups A, B, etc. and ABO grouping, and that antibodies may be of IgM type, and due to this antigen antibody reaction results in the activation of complement and is usually associated with the transfusion of ABO incompatible blood. Since the reaction occurs immediately after starting the transfusion, this type of reaction is also called as acute hemolytic transfusion reaction. About the signs and symptoms: fever, chills, hypotension, chest and back pain, nausea, dyspnea, vomiting, hemoglobinuria, acute renal failure, pain at the site of transfusion, shock, and DIC. DIC is disseminated intravascular coagulation. Next, about the management and therapy. On seeing any kind of these symptoms, we have to stop the transfusion immediately. Keep the IV line open with normal saline. Consider dopamine to combat shock and renal failure. Heparin infusion to manage and prevent if DIC is seen. If the patient in acute renal failure, he or she should be transferred to dialysis unit. Next, about the delayed hemolytic transfusion reaction or extravascular transfusion reaction. Extravascular transfusion reactions are rarely severe and is mainly due to the IgG antibodies like Rh, KEL or Duffy system. These antibodies bring about destruction of red cells by phagocytic cells like macrophages in the spleen or liver. Hemolysis occurs after few hours or after about 3 to 7 days of transfusion. The RBCs which are coated with IgG type of antibodies, antigen, and results in the formation of antigen antibody complex, that is immunoglobulin and RBC complex, and this will sensitize them, and these sensitized cells will interact with the phagocytic cell, usually macrophages, and they engulf the sensitized RBC and will destroy them. This is the diagrammatic illustration of extravascular hemolysis. You can see the RBCs coated with the IgG type of antibody. The phagocytic cell is having receptors to this IgG type of antibodies, and the phagocytic cell will identify the cell-sized red cells and will engulf the cell. And the IgG coated red cells um, will be engulfed by the macrophages and incorporate the cell into intracellular vacuole. Lysis of the red cells within the intracellular vacuole of the phagocytic cell. Next is delayed hemolytic transfusion reactions, which could be due to primary alloimmunization and anamnestic or secondary response. Primary alloimmunization. In this case, patient develops an antibody after a couple of weeks after blood transfusion, and is due to incompatibility of Rh or KEL system. An amnestic response to transfused RBC occurs in patients who has previously been sensitized by transfusion of pregnancy. The level of incomplete antibody is very low and cannot be detected by the standard pre-transfusion procedure like cross-matching. There will be increased antibody production, results in the red cell destruction. Signs and symptoms include fever, fall in HB, rise in bilirubin, and mild jaundice within 5 to 7 days of transfusion, and finally renal failure. Next, about the non-hemolytic transfusion reaction. Non-hemolytic transfusion reactions can be classified as febrile non-hemolytic transfusion reaction, urticarial or allergic transfusion reaction, anaphylactic transfusion reaction, non-cardiogenic pulmonary edema or otherwise called as TRALI, circulatory overload or otherwise called as TACO, graft versus host disease. First, about febrile non-hemolytic transfusion reaction. These reactions are the most common and account for over 90% of the transfusion reaction. These are benign, self-limiting reaction due to presence of antibodies to WBCs of platelet antigen and are usually seen in multi-transfused patients. These reactions occur within minutes of starting the transfusion. Pathophysiology is due to the presence of antibodies against WBCs and platelets in the patient's serum. This can occur due to post-transfusion, past transfusion or pregnancy, and this antibody may react with the donor's WBC. Then this antibody antigen complex can activate the complement system, and this results in the release of pyrogen from WBC and result in rise of temperature. Signs and symptoms include fever, chills, and malaise. Next, about the therapy and prevention, we can give leukocyte-poor red cells to these kind of patients. Antipyretics can be given before starting transfusion, but they must be avoided as much as possible as they mask acute hemolytic transfusion reactions. In the laboratory investigation, we cannot see any evidence of hemolysis and post-transfusion. No reddish or pinkish discoloration of plasma. DCT is negative. No increase in bilirubin and no hemoglobin. Next is urticarial or allergic transfusion reaction. This is type of immediate hypersensitivity reaction. Allergic signs and symptoms appear within few minutes of transfusion. Causes can be due to the presence of allergens which react with the reagent present in the patient's plasma. This allergen reagent complex attaches to the mast cell surface and results in the release of histamine. Signs and symptoms include local erythema, pruritus, hives, hypertension, loss of consciousness, and shock. Therapy and prevention include interruption of the transfusion temporarily. Then keep the IV line open with a normal saline. You can give antihistamine to the patient. When the urticarial reactions disappears, you can resume the transfusion. Next, about anaphylactic transfusion reaction. This is a severe life-threatening reaction which occurs in rare patients who are IgA deficient and have developed anti-IgA antibodies. This reaction developed quickly within minutes of starting the transfusion. Signs and symptoms include cough, bronchospasm, dyspnea in the respiratory tract, nausea, vomiting, and diarrhea in GIT, hypertension, syncope in the circulatory system, generalized flushing, and urticaria in skin. Next, about therapy and management. Stop the transfusion immediately. Keep the IV line open with normal saline. Inject epinephrine if hypoxia persists. Give oxygen. Next is transfusion-related acute lung injury, or otherwise called as TRALI, also known as non-cardiac pulmonary edema. Generally thought to be caused by the donor's leukoagglutinins, which react with the WBCs of the recipient and produce aggregates. These aggregates get trapped in the pulmonary circulation, microcirculation, and causes endothelial damage. Signs and symptoms include respiratory distress, dyspnea, cyanosis, fever, chill, vascular collapse, and X-ray will show pulmonary edema. Therapy and management include oxygen therapy, intubation, intravenous steroids, and we can use red cells, washed red cells in future transfusion for this type of patient. Next is graft versus host disease. This is a complication of blood component therapy or bone marrow transplantation. Patients at risk are immunocompromised patients like lymphopenic patients, bone marrow suppressed cases, post-chemotherapy patients, lymphoma patients, congenital immunodeficiency patients. Signs and symptoms include fever, rash, diarrhea, liver dysfunction, and bone marrow suppression. For prevention, we can give leukocyte poor blood to these type of patients. Next is non-immune, non-hemolytic transfusion reaction, classified into immediate and delayed. Immediate include bacterial overload and circulatory overload. Delayed include iron overload. Bacterial overload, the bacterial contamination occurs during the blood collection or during the blood component preparation, and these bacteria will grow inside the blood, anticoagulated blood, since the blood bag is having nutrients. The bacteria will utilize it and will grow in the blood bag, and these bacteria may release different type of toxins to the blood sample, and these blood gets hemolyzed due to the presence of these toxins. Antibiotics can be used for the therapy in this case. Next is about circulatory overload or TACO. TACO means transfusion associated circulatory overload. Excessive volume or high speed transfusion of whole blood in severely anemic patient can result in the circulatory overload. This can lead to congenital heart failure, pulmonary edema. Signs and symptoms include chest pain, cough, and hypertension. Elderly patients, infants, pregnant women in third trimester, etc. are at high risk. Next is iron overload. Long-term complication of blood transfusion is iron overload, also known as transfusion hemosiderosis. Iron accumulation can affect the function of heart, liver, endocrine system, etc. This iron gets accumulated in the soft organs and results in the normal results in the and affects the normal functioning of these organs. Signs and symptoms include muscle weakness, fatigue, weight loss, mild jaundice, anemia. Therapy includes iron chelating agents, neocyte transfusion to reduce the number of transfusion, as neocytes have long shelf life. Laboratory investigations check all the records to ensure that the correct unit of blood is transfused to the right person. This includes to check the patient details, blood requisition form, compatibility reporting, and labeling. Laboratory investigations include examining the patient's pre-transfusion and post-transfusion plasma from ADTA sample for the evidence of any free hemoglobin or increased bilirubin. Pink or red discoloration in the post-transfusion plasma indicate the presence of free hemoglobin, and this may be due to red cell destruction. Yellow discoloration of the sample drawn 6 to 8 hours after transfusion indicates increased bilirubin. Can perform DCT, that is direct Coombs test, on pre and post transfusion sample. A positive DCT test usually indicates the presence of recipient's antibody on the surface of donor red cells. However, if all the cells have been already destroyed, the test may be negative. Check urine, that's post transfusion first urine sample. Next, about the interpretation of the laboratory findings. If nothing abnormal indicates that no acute hemolytic reaction. If any of the finding is positive or clinical findings strongly suggest a hemolytic reaction, the following investigation should be done in that patient. Repeat the cross-match testing both the pre and post-transfusion sample of the patient against the sample from the back by saline or albumin films technique. Repeat antibody screening and identification of patients pre and post transfusion sample. This is uh, this is all about blood transfusion reactions and about the laboratory investigation of blood transfusion reaction. Thank you for watching. Thank you.